So on the program side, we were asked 517 times to deliver care. 503 of the times we actually were able to. What was really nice for us to see is that in terms of the people we got to, 90% of the cases we could handle by telemedicine. 7% had to be seen by a PCP within 24 hours, and 3% were sent to the ED. We couldn't solve hip fractures. We couldn't solve newly diagnosed cancer. If you're septic or something larger, it's going to happen. You have to send them to the ED. I actually thought our number was probably too low because everyone was so careful about what we got sent on, but that's what it was. It was interesting to note that the location of the ill residents for the various visits that we did really mirrored the distribution between independent and assisted living. It wasn't like it was not working in assisted living or not working in independent living. It really mirrored that distribution of patients. The satisfaction was sky high. Most important point to me was if we asked the patient, these were the first visit only, and if they were cognitively impaired, we did not ask them, would they choose a senior living community based on whether or not telemedicine was there? Almost 90% said yes. And the family members, informal caregivers, it was 97% said they would choose one for their loved one. We also want to know who requested the telemedicine. As you can imagine, a large proportion of it was the provider, but actually, particularly as the study went on, the patients and the facility staff started increasingly requesting it, which was interesting to see. The other question we asked them, why? Faster care, avoiding the ED or urgent care, more convenient, or the providers would often tell us, no available appointment. If we asked them what would have been done if telemedicine had not been available, if the intervention group had to go back to usual care, we asked this question for two reasons. One is we wanted some preliminary data before we actually looked at the true outcome measures. The second is we were very concerned, are we converting things that could easily be handled by phone into telemedicine visits? Because in healthcare, we are so notorious for increasing utilization rather than actually implementing technology to decrease utilization. Half would have gone to the ED, 20% to an urgent care, only 6% would have been handled by phone. So kind of from this, a couple of thoughts that we come down to. First of all, people often talk about telemedicine as being this unique, special thing. I'd argue it's really a tool no different than my stethoscope. It's got a place for it. It's a place to be used. But what it is it's quite disruptive because it changes how we've traditionally delivered care. Because location and time increasingly become irrelevant. We found, it decreased ED use by older adults. It didn't appear to increase other use, and I realized I skipped over it a bit. The PCP visits did not increase, which is one of the other concerns that we had. What could the result be? If I had given this talk 8-9 years ago, I'd be shot by my emergency medicine colleagues. But basically, only the sickest patients may actually come to the ED. We may see a significant decrease of utilization of the EDs. Honestly, if it's going to benefit the patients, I'm not sure I care. The question that worries me significantly is whether overuse will occur, and this really has a lot to do with whether industry will precede research here. And then do we get into this problem where we're trying to prevent overuse? And I think some of the stuff I've seen out of California where telemedicine has to be treated the same way as a primary care visit is we're having a little bit of that occur. The big problem probably, and Wisconsin's actually in the middle of this, is there's a lot of regulatory and legal issues. Where do you have to be licensed? Who holds liability? Is it equivalent? That hasn't been figured out. States are starting to make it required for insurance companies to cover it, but it's not everywhere. And then the question is which visits will be covered. California, it's literally the Wild West, which is why you'll see the big companies completely embedded out there. New York said you could do telemedicine if you do it between a healthcare facility and a healthcare facility, which doesn't help people who live at home. It doesn't help this model. But the question started, and I think the fundamental issue is, I think as the research starts to be done in this field, it will start answering the question of when can we use it, how can we use it, how do we roll it out, what's the right piece.